Welcome to Marney Reid Presents Connect to Develop, where we provide insight from healthcare leaders on the hottest topics and trends. Listeners, we have a really big treat today with Doctors Leonard Buller and Spencer Summers, and they'll be talking about brand building and health system dynamics. Dr. Summers is an attending physician for complex hip and knee surgery at the West Palm Beach location for Hospital for Special Surgery. Hey, Spencer.
Hey, Marnie. Thanks so much for inviting me on the podcast.
And Dr. Buller is and wait for this, folks, it's going to be a big one, the medical director of orthopedics and sports medicine at Indiana University Saxony Hospital, associate professor of orthopedic surgery, the fellowship director for the Indiana University Lower Extremity Arthroplasty and Reconstruction Fellowship, and section leader of adult reconstruction at the Indiana University Department of Orthopaedics. Hey, Lenny.
Hey, Marnie. I'm proud to be here and excited to be with Spencer, one of my favorite junior residents of all time.
I think he said the exact same thing about you before we got rolling. Okay, gentlemen, before we get into the content of this, I'd love for each of you to talk about your institution and how long you've been in practice and a little bit about your practice.
I am about to start my third year in practice in about 2 weeks here. So it's been really a whirlwind. I had one of my mentors told me that you'll never work as hard in your life as your first 2 years in practice. And, you don't think you can work harder than you ever did as a PGY2, but it is true. Your first couple of years in practice, you certainly work harder and you stress more. There's no backup for you. But I've been very fortunate. I'm with a great group of surgeons locally in West Palm. And then as part of the bigger HSS family, I have a lot of mentors and guidance that I can lean on and gather. So it's been a really good opportunity for me, and I'm just doing my best to take advantage of it.
That's awesome, Spencer. It's a great practice to be a part of. So I'm at the Indiana University hospital system. I was recruited here by my senior partner, Dr. Michael Meneghini, who's since left the practice. And I'm actually kind of at a branch campus as well. So I'm at the Hip and Knee Center. IU Health is the largest health system in the state of Indiana. And so the hospital that I work at is a relatively medium-sized hospital, probably about the same size as HSS West Palm Beach. And I have a couple of partners that do joints locally. I've been in practice now for almost 6 years, and my practice involves essentially only arthroplasty. So I do primary and revision hip replacements. About 30% of my practice is revision and complex revision. And one of the reasons that I really wanted to join this particular practice is we take care of the complex joints from around the state. So we have a referral system that basically any surgeon that doesn't feel comfortable taking care of a particular patient, they can send to me basically an open door policy. And so that's very attractive without having to worry about payer mix, insurance type, anything like that. Just take care of the patients that need taken care of. I think the other thing that I enjoy about this particular practice is I get to work with residents and fellows. We have 3 fellows a year, and it's been a treat to teach them. And we also get some time to help doing research. So that's been really enjoyable as well.
So you both are at large academic centers, and it's interesting that you refer to it as a branch campus. I've historically heard about it as a spoken hub model for large health systems and in different tenures of your practice. So can you talk about the differences in building a brand and a practice at that?
Yeah, so I think building the brand in a large academic health system, really any surgeons that are going to be coming out and being employed physicians, which the majority of us doing arthroplasty are moving forward, at least for the foreseeable future, there's your personal brand and then there's your team. And so I think differentiating that into personal brand, some of the ways that I distinguished myself, surgical approach. So I was the only surgeon that was coming out doing anterior approach in the community when I started. So I think that helped a lot. And then online marketing. So my online presence, I was really one of the only surgeons in Indiana, which again, it's kind of a Midwest state, but it is a pretty big market and there's a lot of surgeon competition, but nobody was really online. So having a good online presence where Google search engine optimization and the ability for patients to see my name first really drove a lot of referrals. Within the hospital itself, though, it's basically a first come, first serve opportunity. So whatever white space is open in our clinics, if you had time, the referrals that came in would be popped into your clinic, unless a patient had a specific request for say, my senior partner, Dr. Meneghini at the time. So that was helpful in building the actual referral network. But then when it comes to team building, and I'll be interested to hear what Spencer has to say about this, but a big challenge at an academic center like this, where you don't necessarily have the ability to incentivize your team members, is making sure that you want to be somebody that they're around. And so without financial incentives or time incentives, they're employed nurses, MAs, surgical techs by the hospital system. So there's really no incentive for them to want to help me be productive. And that's how I'm, ultimately rewarded, is by taking care of the patients and doing more cases. So Spencer, I guess I'll let you talk first, but I would want to kind of arch into that a little bit too.
Yeah, absolutely. So I guess, my position is somewhat unique in that, so Hospital for Special Surgery obviously has a tremendous brand recognition within the orthopedic field amongst orthopedic surgeons and other people in that space. And then patients within the New York area obviously recognize that brand. But in South Florida, it's not necessarily the case. So obviously we have lots of transplants that have come down recently from New York. And so then, they flock to HSS because they're used to getting the care up in New York. Now that they're down in South Florida, they want to come to our office, and that's great. But the majority of South Florida people were not really aware of us. And so although it seems like, it would be an easy place to attract a lot of patients to, it is just sort of like any other practice that you got to do the grassroots marketing campaigns. And so that's what we've done. We opened up in 2021. So I joined the year after they started. And so 2021, they basically opened up right before COVID hit. And so we weren't able to make as big of a splash as we wanted to. And so we've really been working hard on gaining that brand recognition in the area and making the connections with the primary care groups around here. Again, we're not part of like a large health system here in South Florida. And so we don't have, the primary care referral networks built into our health system. We sort of have to do it like any other private practice would. So for starting out, I would be going to the primary care physician offices. I'd go to the physical therapy offices. I give talks at retirement communities, which are always very lively. But, I'm just now starting to feel like I'm sort of passing the precipice where the majority of patients that are coming in to see me for an evaluation for a hip or knee replacement, now at this point, the vast majority of them were referred by previous patients of mine. So that's always a good feeling. But in order to build it up, just like Dr. Buller said, I think the online presence is really important. So starting out, I got my Google placard, and I asked patients, who came in, they expressed gratitude at our care. I instructed my staff to try and get Google reviews, and we use our own survey system within HSS. But I think the Google reviews are extremely important. The majority of people, under the age of 70, they're just like when you try and find a restaurant, you're going to find your doctor online, and that's how you search. So that's been helpful. In terms of team building, I guess actually, let me say back to the referral thing. So one of the things I learned is that the majority of the referrals that I was getting in the beginning were actually from my partners. So it was from either my non-operative partners or my shoulder spec partner, my trauma partner, my spine partner. And so, I think we're going to talk later on about the politics and the dynamics and how you sort of integrate yourself into a group. But you really have to recognize that coming out. Like the majority of the people that you're going to get coming into your clinic are probably going to be sent by your partner down the hall. And so you got to be really grateful. You have to be willing to cater to the needs of your partners. And so that's how you're going to get busy. In terms of team building, I think I'm definitely trying to figure it out. I had some good examples in my training of people who did a really an awesome job of that. And so I've sort of tried to emulate them. So one of my favorite mentors, Ryan Nunley, he would run like a 70-person clinic day. And it was just, you'd be working as hard as you possibly could, and all of his staff would. He made a point to order lunch for everybody every day. So I try and do that for my staff. Or on big surgery days, I'll order a pizza in to let the scrub techs and the nurses know how much I appreciate them. Here in South Florida, mangoes are essentially another form of currency, and I have a big mango tree, so I made sure to bring in some mangoes to keep the staff happy. And then, I think it's just having a positive attitude to day in, day out. Everyone gets stressed, and especially like during surgeries, you get stressed. And one of the guys who had just started as a new attending at my fellowship at WashU, he had a great piece of advice. He's like, Spencer, if you're in the middle of a case and it's going wrong, instead of getting frustrated and getting mad, and then, you set the negative energy in the room, he's like, just tell everybody, just take a breath, say, hey, everybody, sorry, I'm just a little stressed out right now. I don't mean to yell or whatnot. Like, I apologize. And so he's like, if you do that directly, they'll appreciate it. You don't want to be the jerk surgeon. Nobody wants to work for the jerk surgeon like that. That idea of the orthopedic surgeon who's like throwing mallets and stuff, that's just like absolutely ridiculous. You got to be a nice person. You got to be a person that people want to work with. So just like Lenny said, like they're not making more money by you doing more cases. So the incentive is really, they just want to work with you because you're a nice person. So that's what I've tried to focus on.
Yeah, it's such a great point, Spence, about taking great care of patients, honestly, is the best way to build your brand. And it's cool to see that after just a couple of years, right, you start seeing the patients that their friends referred them. That was my clinic. I was at clinic day to day. And when you look at who referred, it's majority are just former patients. So that is flattering, and it holds you to a high standard because you want to execute similar excellence for the new patients as well. And then completely agree. I kind of forgot that a lot of that early building is taking those cases that the partners and senior partners don't necessarily have capacity for or want to tackle. And so being affable, being willing to do them is going to keep the door open. But especially with outside referrals, as soon as you say no, if there's competition in the market, it's very quick to dry up fast. So on the one hand, you want to have work-life balance, but on the other hand, you want to make sure that people know that you're available and technically excellent at doing these surgeries for your patients, so they know that they're referring to a good provider.
Yeah, absolutely. I think it's really important. I guess I don't really want to say that you can't say no early on, but you probably shouldn't say no.
I think you need to have a good reason for when you're telling somebody, explaining why or what you can help coordinate, even if you're not necessarily taking care of that patient. I think oftentimes people that are referring are not doing it because they don't want to do the surgery. They just feel like, they need help. And so whether it's talking with them about the reason why they don't feel comfortable tackling the case, maybe providing some pointers, or finding a connection of somebody that can help, those go a far way. Or even just talking to the patient with the provider and having a group group sort of discussion. All those things go a long way and build a lot of trust in the community.
Yeah. One of the cool things, so Ryan Nunley, who was my mentor in fellowship, he gave a great talk to us right before we graduated, and it was on how to succeed in your first few years in practice. And, one of the rules was, don't say no, basically. And then in terms of like clinic and how you run your clinic, we all know, right, when you start out, maybe it was different for you in like a big health system. You might have been busy from the get-go, but a lot of people, they start out and you only have like 10 people on your clinic schedule for the day. And so, part of you wants to condense those all into like the early morning, call all the patients to come in early so that you can go hit the golf course or something. And his rule was like, do not do that. Like, don't call patients to come in earlier. Like if they have a 3:00 appointment, you don't have anyone for 4 hours before, then, figure out something to do for those 4 hours. Cause you want to be there and you don't want to start setting a bad tone in the community or with patients early. And the other thing that piece of advice that he gave was always have like a back way into your clinic. So if you are running late, you don't have to walk through the waiting area and upset all the patients. So I think that was a great pointer.
Yeah, I couldn't agree more about first of all, it's okay not to be busy. And so some people fall into a scenario where they're busy really quickly. I think it's very natural. We're all type A to the max people that want to be at Ryan Nunley level of productivity from day one. But there's no way you can provide good quality care coming out and doing that.
No.
I think I was the same way. Like I saw a couple patients a day for quite some time with a bunch of senior partners in front of me. And that's okay, because it actually gave me time to develop the spiel and work through system issues that I could be really efficient now. So you can really titrate things in, and you get to spend a lot of time talking with patients. I think one of the things that I was the most surprised about, maybe not most surprised, but glad to see, was that spending time in the office with patients and developing a real connection with people is probably one of the favorite things in the world for me, besides spending time with my family. Like people trust you and you really get them to open up. And then when you see them come in debilitated and you transform their lives, it's the best job in the world. So take the time to relish that, especially when you can, when you're not humping it and doing, 40, 50 clinic day patients a day. Like, really enjoy that you have a wonderful job. And I think that pays dividends down the road.
Yep, absolutely. Totally agree with that.
Knowing Ryan the way I do, he needs that back door because probably on the way to his clinic, he got stopped by either several patients that he's too nice to, rush away from, or several staff members who have patients that they want him to take care of. And he's too nice to say, hey, I have clinic. Instead, he would, stop and talk to you like you're the only person in the world.
Oh, yeah. He's never running late because he slept in or something. It's always
no.
He's got like a million things going on. Yep.
Man does not need a lot of sleep. In the corporate world, we talk about political norms and nuances and, being a corporate person and, starting off with large company, you don't really know that there's political norms until pretty much you step on a landmine, especially as the new person. So in the physician world, can both of you shed a little bit light on, as Spencer was alluding earlier, the political norms and nuances that in the last 2 to 7 years you've both become aware of?
Yeah. So I think, in the main thing when you're starting out is, again, to recognize that you are part of a team within your practice, like within your group. You have partners, and there is a hierarchy, right? So there's a hierarchy that I have 2 joint surgeons that are more senior to me. And so the last thing I would want to do is upset one of them. I'm very fortunate. I have the nicest partners in the world. They would never dump anything on me. But if I know that there's a patient with a problem and my partner has, like 8 elective joints the next day and he might not be able to get to them, then I think the politics that I've learned is maybe I should offer my assistance, say, hey, I heard you, one of your patients fell and they have a fracture. Would you like me to take care of it? And I think that really goes a long way when you voluntarily offer to help people in those situations. So that's one thing that I think is important. And then with your non-hip and knee partners, so if we have, for example, we have 3 non-operative providers, and I think treating them just as equal as your other co-surgeon partners is incredibly important, right? So they are just as integral to our mission of taking care of patients, and they're a large referral source. And so being nice to them is very important. That's something I've certainly learned. And then in the overall system that I work in, we are the satellite here in West Palm, and then we have the mothership up in New York. It's really easy to feel like you're on an island down here. So if somebody else is in a situation like that, it's easy to sort of feel isolated. But what I found is it's really rewarding and really important that I constantly sort of have touch points with the people up in New York. And so getting on the weekly calls, getting in the research meetings, texting or emailing the mentors up there and saying, hey, what would you do with this complex case? And that makes sure that the connection stays alive. And at least in the system that I work in, I think that's incredibly important from just a personal relationship, from a practice, and from a political standpoint.
Yeah. I agree with everything that you said, Spence. One of the things that I wish I would have done earlier was understand, at least in the large health system that I'm in, all the layers of the dynamics that go on from the administration of the hospital. What I mean by that is it would have been nice to have sat down with my senior partner and really understand how referrals are happening both internally and externally, who the key stakeholders are, what their goals and visions are for me as the surgeon provider, and better align myself with those. Because I think it's very easy to make assumptions that coming out as a hip and knee replacement specialist, that's what they want you to be doing predominantly. And that might not necessarily always be the case, or things might not be set up in a way to let you succeed in that. For example, your template for the clinic might not be just problem hip and knee replacement or candidate patients. It could be very broad, which is okay if you want to get busy, but you'd have to have a mechanism to cull that down once you are busy enough. So I think that those sorts of things could be helpful to talk about before, or even talk about on a job interview to understand, how much of a lift is that going to be to change things. In terms of specific political norms and nuances at the department level, it's very interesting with finite resources and ever decreasing resources, knowing surgeons' value or a division's value, for example, the arthroplasty division, which is traditionally at IU a pretty productive portion of the department, understanding how our resources are going and being allocated and advocating so that my arthroplasty colleagues get something for that productivity has also been an interesting process. So I think again, making sure that dialogue is introduced and understanding what your personal goals are, because you only have so much time in the day to figure out what's important and what's important to your team members is challenging sometimes.
Yeah, that was an interesting thing that I learned the first couple of years is that, as a surgeon, we really are like an economy unto ourselves. I mean, there's lots of people and systems around us that we support. And it was kind of shocking, and it's a big sense of responsibility. I mean, you have just based off of your productivity, you're supporting the MA, the office staff, the x-ray techs. Then you talk about all, the whole idea of the home health agencies. And that's, I don't know if it's like it is for you in Indiana, Lenny, but I mean, here in South Florida, like the home health agencies are actually kind of pretty aggressive trying to get business and everything. And it's just important to recognize the value that you provide to the system, like you said, and make sure that's, I guess, reflected in how the resources that you're provided so that you can keep providing good care to people.
Yeah, I completely agree.
Do either of you have standing quarterly or monthly meetings? I mean, Lenny, maybe you do, for all of the different roles and leadership that you play, but is there an opportunity to set up monthly or quarterly meetings with the business entity, whether that's, department director or, the office business manager?
Yeah. So we have our adult reconstruction and joint replacement monthly business meeting. So it's over Zoom. And so that's between our entire service line between New York and Florida. So they go over the productivity of the service line and various metrics that we're trying to meet. And then more locally in Florida, we do that ourselves within every couple weeks. I mean, our model, Mike Ast would kill me for saying this, it's sort of privatemic.
Yes, we are going to make him a shirt with our faces on it and say Privatemics forever.
Yeah. So, I mean, I'm employed here by HSS, but, I guess the way I'm compensated is based off of collections, which would be like any other private practice person. And then, we have center and then we have other small ancillaries. And so it's not like a classic employment model. And so there are definitely some business aspects that I've had to, or business things, for lack of a better word, that I've had to figure out and educate myself on. And so we try and have meetings every few weeks with our local group in Florida to go over all that stuff.
It's interesting how on the one hand, at the personal level, as a surgeon, I think that Spence, you're exactly right. Understanding the dynamics of how you can improve your billing and collections and improve your practice's growth is super valuable. And those meetings are really important. One of the things that as I've evolved into a couple of other roles that I find challenging is making sure that I'm aligned not only with my personal goals as the surgeon entity, but that those are aligned with the system goals. So for example, within the hospital, it's a multi-specialty hospital that while I'm one portion of that, they want to grow general surgery and urology and all these other things. So understanding that maybe sometimes orthopedics isn't necessarily going to be front and center is challenging to the ego. And similarly in the department, while I think arthroplasty should be number one for everything, it's a balance to really understand which battles to fight and which ones not necessarily to fight, or not necessarily fight, but where we can really find shared goals. So it's like this political speak and administrator speak sometimes that you have to do to really reach the same goal for your group, but it involves some giving up of that self and trying to see where the team goals are. I'm not sure if that makes sense.
Oh, it makes sense. Yeah, absolutely. I didn't appreciate the scarcity of the political chips that one can play until I asked for a robot at the hospital. And so I got my robot, but then after that, I had no more chips to play. So that was all the political capital I had.
Did they take the peanut butter out of the doctor's lounge after you got the robot?
They did. Yeah, there's no protein. There's just carbs.
Costco packets of ramen for you now, buddy.
But it's so true what Lenny was saying. I mean, we always think that, obviously orthopedics is the best and it should be the most important priority for every health system. But, there's different interests at stake. And so just like you alluded to, understanding the interests of each stakeholder and what they're trying to get out of it is it's different in every situation you're in, but it's a really important process to navigate and figure out. For example, I operate at a hospital and I also operate at a surgery center. There is a bit of co-ownership. The parent company of the hospital has an interest in the surgery center. And so when they're like allotting block times or this or that, I'm finding out that, hey, maybe they actually want me to do those cases in one location rather than the other. And they won't tell me that directly, but I see it indirectly in how they're trying to steer me into where I'm booking my patients. And at first I was like, what is going on here? But then I figured out, oh, okay, I see now why you want me to do that. But so, that's all that stuff's new. You're not going to figure any of that stuff out until you get into the situation. But yeah, you don't want to step on the wrong feet and you don't want to put your foot in your mouth. So you always want to figure out who the stakeholders are, what their interests are before you jump to conclusions or do something that you'll regret.
Yeah, it's so interesting how site of service is this unwritten or unspoken about important thing now in the inpatient world. And so I had the exact same experience where I had been operating at the ASC for quite some time. And right now I'm only on the inpatient side in HOPD. Even though they're same day discharges, it's just site of service is important, and it wasn't necessarily directly told to me, but same exact experience.
Reading nuances, which is not something that I think you are trained in at all in residency. So you both have alluded to a lot of really intriguing things that someone who has made a lot of mistakes, and quite frankly, that's how I learned all of the political norms during my years at, Fortune 500, Fortune 200 companies. What was the hardest aspect to adjust to when stepping into your attending physician and leadership roles that you didn't realize was going to be needed to adjust to in your residency and fellowship?
I think, I guess I'll go first. The biggest learning thing for me was managing other people and being the captain of the ship and figuring out how to carry myself. So both in the clinic and in the OR. I think the OR was actually easier because we just were trained to operate and we know what we're doing. And so that's our place. But in the clinic, figuring out how to lead and create the workflows that Lenny alluded to before, like the efficiencies. So how to do that and work with my MA, work with the x-ray techs, and now my PA, and figure out how to keep everybody happy, how to keep them all busy and engaged and motivated. That was something I didn't really appreciate would be as hard. But I think that's one of the more rewarding things. At this point, I feel like I have such a great team, and I'm just like praying every day when I go into work that no one's going to quit or something, because it's like sort of too good to be true right now. But that was probably the hardest thing, is to figure out how to, all of a sudden you're the boss of these people, and how are you going to set up your practice? So that was hard.
Yeah, I think I fell into a pretty fortunate situation where I was the junior partner to an extremely efficient, well-liked surgeon in Dr. Meneghini. And so all I had to do was basically plug and play and then hope that he doesn't dislike the anterior approach so much that he lets me go, because he's just such an anti-anterior approach. But in reality, from the office standpoint, it was really not that challenging because the whole system was built to maximize efficiency for him. And so I just did the same thing. I think it was actually the opposite for me. Was the OR was a challenge. So I started right during COVID. So I had a shutdown within the first couple of months, didn't get the reps in, then another shutdown because the hospital system lost basically all their anesthesiologists, and then another one because we had staffing shortages. So there were a lot of fits and starts. So even though I knew what I was doing technically and I had some consistency with teams, the variability in the teams was a challenge, and trying to put together some systems, whether it's PowerPoints or laminated photos of my setups, it felt like I was rebuilding the wheel often. And then probably the biggest surprise in my attending physician role was the challenge that I found with educating. So Spence might remember, as a chief resident, I felt like I could give lots and lots of autonomy to the junior, and I thought that I did a pretty good job teaching. And for whatever reason, when it became ultimately my patient, I had a very difficult time handing things. And so I talked with my senior partners and colleagues from HSS about that, and it's developed a lot, but that's still probably the most challenging thing that I've found in practice, from a, I guess, role that I have to fulfill as an educator, but also as a provider, the balance between allowing somebody to operate and work, but also providing the excellent patient care that I think I want to deliver. So that's a big challenge.
I mean, your comment just hits the mark. I mean, I feel very fortunate that honestly that we haven't set up our fellowship down here yet, because I've been able to just sort of get the reps in myself and get comfortable the first 2 years, because that would have been really hard being on my own learning curve and then trying to teach somebody. So when we do get a fellowship, probably in the next year, I think it'll be a lot easier. But those first couple of years would have been really hard for sure.
That was probably one of my most vivid memories of that topic. Was I was in the OR with Mike Ast about 3/4 of the way through my fellowship, and I asked him exactly that. I said, you do such a great job letting me do and guiding me through this. Like, how long did it take? He's like, 5 years. It's about reps. It's about understanding and reflecting on what you've done to see how you can do better. And so I think that it really does take a lot of time, though.
Well, gentlemen, this has been one of the most incredible discussions that I've had thus far on my podcast. So I thank you both for that. So let's leave this with the biggest tip, could be one, could be three, that you would give to anyone out there who's either building a new brand or has gotten some feedback and needs to revamp their current brand.
Yeah, I guess I can start. I think it should always start and be centered in the patient experience and just having a good outcome for your patient. So there is no better referral than a patient who is happy with the care you gave them. So, people get lost in the weeds with the newest technology or approach or surgical fad or this or that. But if you really want to build a long-lasting brand and you want to build a busy, flourishing practice, it starts with providing good care. And so focus on the patient experience, make sure that every patient feels like you're treating them like family, and that even if you do have a bad outcome, if the patient has that connection with you, they know that you did everything possible to give them a good outcome, then they're still going to be grateful that you're helping them get through whatever untoward event happened. You just have to focus on the patient outcome. Don't get lost in the weeds.
I think ultimately that's the answer that every surgeon should know is if you provide excellence in patient care, you're going to be successful. And those patients are going to tell other patients. So if you focus patients first, that will always be a winner. I think the other thing that's crucial in this conversation is reassessing your own personal values and priorities with some frequency. That includes if you have significant others and families, understanding what their values and goals are. What I see as a challenge is surgeons want to grow and they want to get busier and their lifestyle can expand. And it's really incumbent upon us to be financially literate and financially and fiscally responsible. There's an inherent conflict of interest in surgeons that are over leveraged, and I can see where that can lead surgeons to making questionable clinical judgments. And that isn't talked about a lot, but we see it. And so starting early and having a financial plan and sticking to it will guarantee that you make the right decision for the patient every time. So I think those are two really important things.
Well, thank you again, Lenny and Spencer. What an incredible discussion. And for our listeners, if you'd like to learn more about Drs. Buller and Summers, please check out their bios in the show notes.
Thanks so much, Lenny.
Thanks, Marney.
Thanks for listening to Connect to Develop. You can find more interviews and Marney's Minutes on my YouTube channel at Marney Reid Presents.